Thank you, sir. So I'm going to talk about how to set up an ROP screening program, or if you have one, how to expand it. These are 5 points that are given in the National Operational Guidelines. So that's Government of India's. It's available online. So I'm just going to summarize it with some personal experience in Karnataka. So firstly, if you are beginning to set up an ROP screening program, you have to do the need assessment, which is basically how many NICUs are there in your area, how many people are already doing it. So this is the national level. So we have 3.5 million babies and less than 200 ROP specialists. So this is when you talk to stakeholders, this is what you want to be telling them, because then they'll realize, oh my God, this is a problem. Many of them don't even think that ROP is a public health problem. So these are numbers that are available and you can extrapolate them. This is an editorial written where why is ROP such a big problem? And a lot of this you will have to convince your neonatologists or your medical colleges to set up an ROP division or an ROP unit or at least an ROP clinic. The next thing is to assess your at-risk population. So here you need to deal with neonatologists. Firstly, become a member of the National Neonatology Forum of your local chapter. As we've shown here, we've been able to reduce the severity of Zone 1 ROP in just 1 year of improving neonatal care practices, and that we did by creating a chapter in the NNF. So we didn't go as ophthalmologists and tell them how to do it better. We told the neonatologists to go and tell their own brethren how to do it better by simply monitoring their disease and publishing the downward trend after. This is another publication which eventually became the national guideline, where the first screening was advised before discharge. You don't have to wait for 30 days because many babies don't come back in rural areas. So if you screen once before they've gone home, at least you have the data of the mother and you can call back appropriately. And we showed 12 times higher follow-up and less attrition to follow-up. And the next thing is, of course, what are the reasons why they don't come back for follow-up? So 52 of them we published here, and some of them are modifiable, and the best way to do it is to expand your network. If you're able to screen in other districts through your teams, then when they follow up, if they go back to their mother's house or their husband's house, your team is there to pick up the screening. The next thing is the step 3 that is advised by Government of India is to assess the eye care providers. That's you and your fellows or your people whom you've trained or you're going to work with. Some of them are comfortable, some of them are not doing ROP. So world over, and this is something we all have to learn, that ROP screening programs have been a fairly big failure if it is completely kept into the hands of ophthalmologists. And these are reasons published by the London School. And as we go forward, it is supposed to be a pediatric-led model. So the more you empower neonatologists to call you, both the medico-legal owners and the clinical logistics will become better managed. So what do you do when you have limited specialists? And this is the story all over the country, and this is where I'm going to share our experience of 17 years now in Karnataka, where we were trying to replace the so-called ROP specialist with non-physician graded certified technicians who are going to use wide field imaging. So this is the KidRAW program, established 2007. We slowly expanded, and this is how every program we help to now mentor across the country or the world. We say start off with wherever you're comfortable with, wherever your friends may be neonatologists. It could be the private sector, and then slowly move on to the public sector. So from 3 hospitals, we are currently now at about 144. So initially we used the American camera, and then we've used the Forest camera, and this was a public-private partnership. So the best way to make your work most impactful is to work with the government, even if you are in the private work. And for that, you will at least need 6 months to 9 months of your own data to convince them that, look, I know what I'm doing. These are models that are already there. I'd like now to offer my services to the government sector. And yes, it takes a lot of going back and forth, but eventually now that we have models in so many states going on, it's going to be much easier. But back then we didn't have a precedence, so we were really helped by extraneous reports. So Ministry of External Affairs picked up the KidRAW program, and the Harvard Business Review then picked it up, saying that this is a model that the West should follow because it's low cost, it's affordable, and it's highly expandable. And the next thing is, talk to business houses, talk about how sustainable it is. So both IIM Ahmedabad and Bangalore did business case studies on us and said, so we do free screening and free treatment for every baby born in a government hospital in KidRAW. And yet we are not only, we break even, but we are profitable enough to put back our money into our own research. So all the research that you see here is basically funded by our program. And that is done by a break-even cost. And we might be very poor in finances, but there are people who can do the work for you. So long back, this is the very first iPhone in 2009, if you all remember, the first pinch and drag. And I mean, today all of us are looking at these images on our mobile along with so many other things. And therefore, the turnaround time is very important. If you are using telemedicine as a model, it will not be enough for you to go back with the report a week or 2 weeks later like the ROP study did. You have to get back within minutes, because if the mother leaves the center and is not told that this baby needs treatment in a day or two or at least a week, then sort of lost the purpose. So Government of India then took it to the national, international level, and in fact, this won an international Innovations Award through Government of India's program. That's called the CAPAM Administrative Awards. So this is where we are now. We started at 3 hospitals. We had 144. We're close to 300,000 babies and over 4,000 babies that have been treated. Now, what's important is that this model has now got accepted. So those of you who still have that trepidation, oh, how can I allow a technician to go and screen in the rural outreach areas? This is, by the way, in the Government of India's document. So today, in fact, we are the first country to allow not just doctors, but trained and certified technicians to take these images in the rural areas. And this is the important word, trained and certified. So that's where you need to move forward and make sure that you've at least covered your legal basis. So this has been named by the United Nations Development Program and by the CDC. So Center of Disease Control, the Australian government actually studied the model because they were trying to see how to prevent costs of airlifting babies from the center of Australia and to take them to the 2 coastlines just for a 15-minute exam. And they said that telemedicine is the way to go. And this is from the Australian government report, not ours, which says that if you do indirect ophthalmoscopy and you're not adequately trained, you are opening up a Pandora's box of medical legal litigations. And this is important because we've had very, very large court cases against pediatricians, but also ophthalmologists in our country. So this was the cost barrier breaking. We worked with Indian industry, and this is the Make in India model 2014 onwards. It's not only a fraction of the cost, it's also more portable, and we've published the advantages as well. This subsequently won the BIRAC award both for the company and IIT Madras, who are our technology partners. I have no financial interest here because we served as non-paid principal investigators for that study, but we worked on a government grant at that time. And the new device now has an angiography model as well, which is very useful in the era of anti-VEGF. Now, how do we do the training and accreditation? So fortunately, before COVID, we had sort of mastered this area of doing it online. So nowadays, instead of spending 30 days, technicians spend less than a week or 2 with us, and the rest of the training happens online by correcting their posture, their methodology, and so on. But we still prefer 30 days, 4 working weeks. If they can spend with us, then we can certify them as trained technicians. And now we are working on 2 innovations. One is artificial intelligence. As we are going to be producing tons and tons of images, we are now, there are at least 3 publications from our group where the sensitivity is around 90-92%, but we are now in the process of integrating it with the telemedicine model. So as the technician takes it, the score comes out, and this we are not doing in isolation. We're doing it for Government of India in a BIRAC grant. And finally, this is what excites me the most. Our lab in Bangalore, we've been able to predict whether the baby will get disease or not by doing their tear fluid analysis during the first screening. We now have about 3 publications. This is good, but there's still work to be done where we are now prospectively following them to eventually come up with a risk score. And the 5th step is health communication, and this has already been deliberated by Sir, that the National Task Force and the, did an amazing job, and we were helped by the Queen's Diamond Jubilee Trust, but that was just the impetus. I think the real work has been through the Indian ROP Society, and we are in our 8th year now, and as Sir mentioned, from 32 members, we've now crossed over 200. And each of these are, dedicatedly doing a lot of ROP work, so they're not simply there for the academics. Let me give you one of our achievements, that we were the first professional society in the world within 7 days of lockdown in March of 2020. We put out how to modify the current ROP screening guidelines so that less babies are missed. And this, our guideline was, of course, not peer review published that quickly. We put it up on our website, but eventually peer review published. And it changed the way all our neighboring countries also did ROP screening. And the medical legal liability is very big, and this is something that we need to know. This is one publication that we had in the Lancet recently, where we're taking from the successes of the polio program, and we desperately need a brand ambassador and many other things that we can learn from the success of the polio program. I'm just going to end with the impact you can make. This is a publication where we said if 9 other states which have a high ROP burden are going to follow follow the KidROP model, what is the amount of blindness you can prevent? And that is used, that is calculated by the number of babies prevented from blindness into the life expectancy, into the per capita income. And India is only getting richer, stronger, and more healthier. And at least in the Karnataka model, it's over 4,000 crores of rupees that we've prevented. And this will be 10x more if we continue to do it in other states. Thank you so much for the opportunity.
Thank you very much, Anand.